Well, good afternoon. It's 12:30, and this is Julie Cox8. Hello, here with Dr. Cox for this afternoon's webinar on force measurements. It's continuing last time's discussion. I want you to know there are two handouts in your handouts column. The handouts from part one, because he's going to do a little review of that, and I know you'll want some of those, and the notes for today's part two. So you'll have two sets of handouts. If you look in your panel, it says handouts, you can go download those. And I'll make those available as well later today. Notes are there. He's going to do some demonstration of hands-on with the force table again, and I'll explain how to be sure you can see him large when he's doing that versus the slide. And without any further delay, I'm going to turn this over to Dr. James Cox, lover of all things spine, and let him continue with today's webinar.
Thank you, Julie. Thanks for studying with me today. At the outset will be a brief summary of part one of the force table distraction method, and I'll revisit the January 6th meeting. However, before I go into that, this morning on my literature search from PubMed, I received this paper. Some of you will remember that we have talked about this text from 1966 called The Biology of the Intervertebral Disc, published by the Purvis Bone and Joint Research Labs in the Royal Shore North Hospital in Queensland, Australia. We talked about glycosaminoglycan, the degenerative changes of the disc with the deficiency of same. I want you to note that this paper, and I'm going to just briefly cover this because it's so exciting, that same institution are still working on intervertebral disc degeneration reversal and what they call the chondron. You'll note here in this paper from European Cells and Materials, which just came out today, 2021, it's the distribution of perlicon within the intervertebral disc chondrode and how it affects the changes with heparan sulfate proteoglycans. So you can study this on your own. You can pull the paper up and read it. Basically what they're talking about, and you'll see it's Professor Melrose from Raymond Purview's Bone and Joint Labs. Notice how decades from 1996 to 2021, that same institution have been working on the intervertebral disc. Do things move slow? Yes, things that are good usually do. But in this paper, it points out about the use of heparan sulfate in the study of the cellular changes of the intervertebral disc. It talks about a new arena of cellular regulation, providing avenues of treatment of disc degeneration and the elimination of low back pain. Yes, you'll read in here as you look, you'll talk about the chondron. That is here, if you look at the nucleus pulposus and the annular fibers of the disc, take a little box and look into that part, you'll see the chondron. You'll notice here the nucleus of the cell, the cytoplasm of the cell, the matrix of this cell surrounding the chondron, and this is where the degenerative changes take place within the disc. The paper points out that the study of the pro-inflammatory cytokines, which you and I have studied, tumor necrosis factor alpha, interleukin 1b, interleukin 6, how these are the chemicals that bring about discal degeneration, and how the upregulation of this certainly is playing a big future in stopping degeneration, stimulating regeneration, stopping the chemical inflammatory changes of these cytokines. So that in essence, it's talking about the transcription factor within the intervertebral disc that's activated by hypoxia. Remember, the intervertebral disc has a high metabolic rate, demanding a lot of glucose and oxygen for its metabolism. So that the hypoxia, and it may be essential to regulate nuclear heparinase activity. So this provides cell survival properties to the intervertebral disc and regulates disc degeneration. To that end, I have to tell you, I've followed this since 1966. I've made chondroitin sulfate and carotene sulfate and glucosamine sulfate, formulated it and given it to patients with some rather outstanding positive comments from people. I just want to share with you, doctor, that this is an ongoing study, decades long. And you and I, as chiropractors, using this formula, are involved with treating an epidemic of disc degeneration and spinal stenosis. Let's move on now. As we said in part one, what's going on in this intervertebral disc? This is Kim Lombardi's patient that he treated, is overweight, has several comorbidities. What goes on in the disc when you and I treat them to bring about relief? Degenerated discs certainly exhibit greater reconstruction after low tension. We said last time we studied 1/10 and 50% of body weight traction. What did we say? We said by this paper by Isidore Horobetti and others that low force distraction created a better long-term clinical outcome than high forces. So this paper came out about the forces delivered by a chiropractor doing manual and automated long y-axis Cox distraction. And so this paper pointed out that that the peak axial load in manual distraction was 74 newtons. We pointed out that when you use automated distraction, as I'll show you later, for example, manual distraction will apply a force of manually applied here of 12.6. When you do automated to 16.5. Here at Flexion with automated distraction, we get 9.6, but then it goes to 30.6 pounds. So when we start, we use low force. As we move into automated, realizing it is a much higher force, we tolerance test the patient's tolerance carefully. We covered the work of Gay at Mayo Clinic in this paper, that they found that they agreed basically with the work of Gudavalli and Cox, as done in the studies at Loyola and Heinz VA Hospital National and Palmer in a collaborative study. Gay pointed out that axial distraction, long y-axis, decreased intradiscal pressure by 99%, more than with either flexion or extension added. Gay went on to say that they were isolating a removed spine in a group of segments. We isolate to individual intervertebral discs. This paper came out that manual therapy spinal mobilization, which is what they call 50% of our work, is preferable to conventional physiotherapy to reduce pain. Spinal stenosis is a very common thing that we all must prepare for every day by study and technique and watching our research, because by the year 2025, 59% of all people will have spinal stenosis. This is a study done at Palmer on intradiscal pressure changes in the cervical spine. This was published in Evidence-Based Complementary Alternative Medicine at Palmer, Heinz VA Hospital, Loyola University Stritch School of Medicine, and mine and George Yoakum Clinic and Ralph Cruz's clinics. So the research on the cervical spine, this was done at Palmer. You'll note that the placement of the cervical spine at the split between the cervical and the thoracic spine, we note that we have measuring intradiscal pressures as we apply C5 foramen magnum pump and with occipital restraint to measure distraction forces. These are the forces of the intradiscal pressure, all dropping here as we apply long y-axis distraction, manual or with occipital restraint. Each disc has been measured for you. You can study these. You can note that 4, 5, 5, 6, 6, 7 all drop dramatically. C7T1, which in all literature today shows that it behaves a little different than other discs. The question being, is C7 really the first thoracic vertebra, and there are really 6 cervicals? The mean intradiscal pressures in the neck at 4-5 drop 502 millimeters, C5-6 367, 6-7 414 millimeters as you and I apply the technique that we will be studying shortly. Gudavalli et al. Also published this in Trials in 2015, that when you deliver three forces, 0 to 20 newtons, which is 0 to 4 pounds, 21 to 50 newtons, which is 4 to 11 pounds, or high force 51 to 100 newtons, which is 11 to 22 pounds, that the medium force gives less iatrogenesis and better clinical outcomes. This paper was studied by clinical proficiency, and what this paper shows is that when you apply these forces as trained with a force instrument, that 97% of the time with that visual feedback that you're going to see, you could mimic and reproduce the forces in the cervical spine. This was the work done at Palmer. Here you see the patient on the instrument, the force sensor in the headpiece, force plates under the trunk and legs in order to measure the forces that are going into that spine when you and I apply long Y-axis distraction, manually or automated. You can see the forces of treatments by an experienced doctor here. And if they're inexperienced, they're not that good. Takes training, that's why we have the certification course. We move into part 2. And before we go to the instrument, we have looked at what happens when we apply Cox long Y-axis distraction manually or automated. But what does the literature show of the determinants of pain relief? What must take place in that spine in order to give a patient relief? Well, if you look here, Chung's paper in radiology, I'd urge you that radiology is one of the top radiology journals in medicine. But in studying herniated disc with real-time MR evaluation under distraction, he said this: please note, this is what you and I are doing. Traction on the herniated lumbar disc and its surrounding structures resulted in disc shape, disc reduction with opening in the intervertebral disc space, reduction of herniated disc volume, separation of the disc and adjoining nerve root, and widening of the facet joints. We would offer that these are probably very positive things when treating a spinal stenosis patient. And then Wong, here publishing in Spine Journal, volume 40, number 17. Ask the question, do the participants with low back pain who respond to spinal manipulative therapy, do they differ biomechanically from people who don't respond to spinal manipulation? And Wong said that after the first spinal manipulation treatment, those who responded positively displayed statistically significant decrease in spinal stiffness and increase in multifidus muscle thickness that lasted for 7 days. We increased physiological range of motion to have a positive benefit of what we do as manipulating physicians. Wong went on to say, and note this, published here in the European Spine Journal last year, the nonspecific low back pain patients who respond with greater than 30% relief show higher apparent discal diffusion, anistropy, and apparent diffusion coefficient than do those people without a positive response. In other words, they get a better circulation from vertebral body through the end plate into the nucleus. This was done by MRI, performed before and after spinal manipulation on day 1 of care. Is 30% relief good? Well, we'll look at that shortly. Here's Beate. Beate wrote in the Orthopedic Sports Physical Therapy Journal that the study to determine differences in diffusion tensor imaging, the flow of fluids into the intervertebral disc, that people who had an increase in the flow of fluids into the disc had a greater clinical relief of pain than did those who did not see stimulation of diffusion of fluid into the disc, as noted under lumbar magnetic imaging, before, during, and after distraction. So you must have, as they say, that you must have a difference in the diffusion of water into the intervertebral disc. Then Kuo wrote that distraction treatment is effective in enhancing the nutritional supply, and you and I just discussed chondroitin sulfate. That is, chondroitin sulfate is glycosaminoglycan, the factor within the disc that imbibes fluids to 9 times its own volume, gives the disc its property of turgor. But Kuo wrote here in Spine Journal, volume 39, number 9, that distraction is effective in enhancing the nutrition supply and promoting disc cell proliferation of degraded discs. I sense from this, and when I look at the first study I gave you, an extension of the biology of the intervertebral disc by Peter Ghosh, that we are getting closer and closer to coupling, in my opinion, of the nutrition and the effects of distraction manipulation in stopping degeneration and inciting regeneration of a disc. Palfrey wrote that diffusion for all contrast agents was about 25% faster in the nucleus than in the outer annulus. Geyring wrote, if you remember this famous paper from 2006 in European Spine Journal, that if you compress and degenerate a disc and distract it, that there's an active pumping of nutrients into the disc, and this distraction would reverse discal degeneration. There was a study done in complementary therapies in 2019 on 150 patients with low back pain treated with Cox flexion distraction versus high velocity, low amplitude. I had nothing to do with this paper, but they showed that flexion distraction showed an improvement of at least 50% in pain and 50% in disability, and high velocity 8%. So when you read papers like that, it's up to you to decide if this may have some place in your clinical expertise. Joel wrote this paper about effects of manual therapy using joint mobilization and flexion distraction in chronic low back pain and the disc heights. They found manual therapy using flexion distraction considered an effective intervention to increase disc heights in people with chronic low back pain. Went on to say that flexion distraction appears to be an effective intervention for pain and disability in people with lumbar spinal stenosis. Remember, within 4 more years, almost 6 out of 10 people over the age of 60 will have this condition for you and I to treat. The references in these papers, if you look, you'll see the papers we were talking about are referenced. Gay, Schlieser, and Ralph Cruz, who did the work on cervical spines, Gudavalli, myself. We are the source of many of the references in papers using our work today. This was another study on chondroitin sulfate injection. These chondral protectors, that there's a progressive loss of cartilage and decrease of chondroitin sulfate in osteoarthritis with low back pain. So they found that the optimal dosing regime, that when they gave them, there was a progression of relief of pain, reduction of functional disorders in people who were given chondroitin sulfate. Now, review from section 1. Remember that when we distract and we apply a force, what is happening inside that lumbar spine? If you remember here, pre-flexion distraction, the interspinous spaces, L12 are 0.69 centimeters, 0.80, and 0.75. When we apply the force, which you'll see shortly, to this spine, the one that was 0.8 increases to 1.17. The one that was 0.69 to 1.10. You see there's an increase. If you look at the interspinous space when you and I deliver flexion distraction. Now, how does that equate to the change within the osteoligamentous canal, the posterior disc space, and the faucet joints? That's the future research question, isn't it? Then when we stop distraction, 1 minute post-distraction, we see that the one, for example, that it was 0.8 is now 0.96. So there is a movement. This is an elastography study of the interspinous ligaments and the mechanical changes in the lumbar spine when we apply Cox technique. If you look here, we note that neutral from L1 through L5 is 13.24 centimeters. Under flexion, it increases to 17.51, marked increase in interspinous spaces. When we go into extension, it reduces to 9.75 centimeters. So you see quite a dramatic change when you apply flexion distraction, manual or automated, which we'll show now. And the next step will be what? To determine what are the complete biomechanical changes within the spine when we apply distraction manipulation, and what will be the clinical outcomes with various forces of application to lumbar segments. Let's move to the instrument and study together.
Okay, while he's doing that, I'm going to shut off the webcam. So I'm going to move the webcam. I'm going to start the table. You should see the table moving.
When we apply manual or automated long y-axis distraction and mobilization to a spine, we use the least force that gives a positive clinical outcome, and also which produces what Wong, Beati, Kuo, and Chung showed us of increasing physiological range of motion, dropping intradiscal pressure, stimulating circulation into the disc, and increasing nutritional supply to hopefully change some degenerative into regenerative changes. This patient has L4-5, L5-S1 disc degeneration. At one time had atrophy of the gluteus maximus muscle. I always use the lowest force possible. This patient's like most, they say, "Doc, that feels good, do more." You do what's tolerance for the patient and gives the best clinical outcome. If we look at the instrument, I'd like to show you the difference between 2, 4, 6, and 8 pounds of distraction manipulation at a given segment. In this case, I'm going to use L4 because both L4 and L5 are degenerated with spinal stenotic change. Thenar on the spinous. I apply a manual distraction force. Now on the chart, if you will, I'll take my hand off and I want you to notice I reach the taut point. And I would ask that you follow this type of recommendation until something better is known. I make the contact, this force are equal, and note that the line will elevate to what we call the taut point, the barrier of elastic resistance. You see how flat that is? That's tautness. I've taken all the tautness out of the ankle, knee, hip, and spine below the L4 level. Now I apply 2 pounds. If you look on the right hand, you'll see it says 16. Now, just watch. When I go up 2 pounds, you see the movement of the current. The light blue line is my contact. The dark blue line is the force applied. The closer you make these two to equal, but the blue a little slightly more than the light blue, is the force of flexion distraction. That's 2 pounds. This will give, in our findings, good clinical outcome without over-distracting and causing any adverse effects for the patient. So when we start with 2 pounds. Now imagine if I'm treating a 75-year-old lady, very frail with comorbidities, that 2 pounds can be much more suitable for tolerance than if I went to 8. But with this patient, I'm going to go to 4 pounds now. I move to the taut point, and then with that chart, and you'll get so you don't have to follow that visualization to know 4 pounds. V of E. Here's 4 pounds. Now you watch the chart and see if that's 4 pounds. I'm going from 14 to 18. Now if I want to increase that to 6, V of E, Without looking at the chart, you will know by tissue tension sense, or you can follow the chart, that I'm going here from 9 to 19. That's maximum that I ever use. 8 to 10 pounds is maximum. So that shows you the force application manually delivered with the instrument. Futuristically, on the board, will be studies to show how much distraction in force, newtons or pounds, is creating increase in the interspinous space and thus reducing stenosis. Manual. Now please watch automated. I can lock the instrument and apply automated, but watch how much stronger automated is. Watch the force. I'm going from 10 all the way up to almost 28 to 30 pounds. So when you start using automated, you want to make sure you do two things. First, make sure your patient is showing good clinical relief of pain, disability, and increased range of motion. And secondly, that you tolerance test and say, are you okay with this much force? Because you can see how much more force we are applying with long y-axis automated distraction. People like this. They say it feels good. But the big difference, please note, let's say that I'm treating L1 through L5, and I'm applying long y-axis distraction, and I'm going here from 9 to 26. I'm applying 15, 20 pounds of distraction, but I'm dissipating that over 4 lumbar intervertebral disc segments. Versus if I come down to just L4, I'm going to use even less distraction because the force is now working at 2 motion segments, 2 triple joint complexes, 2 disc and facet joint levels. Then, as we institute physiological range of motion, we apply distraction and lateral flexion in a smooth, coupled, rhythmical movement. And we can again define on the force chart the degree of lateral flexion, or please note the degree of circumduction, which is a combination of flexion and lateral flexion, the strongest movement that we can apply to a motion segment in the lumbar or cervical spine. Those of you who come to certification courses know that we drill you pretty thoroughly until you can do this yourself in your own clinical practice. So I'm going to lock the instrument here. I'm going to move to cervical spine. In a cervical spine, when we teach you, we use foramen magnum pump and C5 as the teaching tools to learn the difference between 2, 4, and 6 pounds of distraction. Visualize in the cervical spine, my contact, the tiller bar, my hand move in unison to the taut point. So I start from neutral, note the taut point, and the 2 pounds of distraction force. 2 pounds. Very gentle, whether performed at the foramen magnum pump, or if I move down to the C5 segment, taut point, and again, 2 pounds of distraction force. Start at this force. People, can I ask you a question? Have you ever noted that sometimes the most gentle technique gives you the best clinical result and the happiest patient? Start gentle. It's remarkable how little distraction can reduce stenosis and give relief. That's 2 pounds of force. 2 pounds. Here's 4. 4 pounds of force. That's maximum that I ever use in treating a cervical spine. Now, occipital restraint, those of you who use occipital restraints for treating lower cervical disc herniations or upper thoracic spine T4 syndrome, oftentimes with scoliosis, you know that we will use a contact in the mid-thoracic spine to apply long y-axis distraction, moving up through the thoracic spine. And we know from the literature that treating of the upper thoracics will bring about increased cervical range of motion at least as well, and some authors say better, than treating the cervical spine itself. So we can also institute lateral flexion in this hyperkyphotic, tense, hypersympathetic upper thoracic spine. We can apply long y-axis and lateral flexion in a coupled movement, or we can apply long y-axis, distraction, rotation, and lateral flexion in a smooth, rhythmical, coupled pattern. So when you're doing this, what's going through your mind is the past research that we have done, showing that we increase foraminal area by 28%, we drop intradiscal pressures inside of the disc, we create physiological range of motion, and we create afferentation, normal excitatory impulses to the somatosensory cortex to produce the bold changes within the brain and the production of endorphins and cephalons and serotonin to reduce pain, at the same time dropping interleukin-6, tumor necrosis factor, the chemical pro-inflammatory cytokines. We're thinking about warmth. We are increasing physiological range of motion. We are stimulating circulation into the disc itself. We are bringing nutrition into the disc. We are causing, in the work of Wong, strengthening of the multifidus muscle in the low back, which is a notorious atrophied muscle in chronic pain. So I hope that I can interest you in using this in treating spinal stenosis in patients who do not tolerate high velocity, low amplitude thrust technique, people who have degenerative disc disease, diffuse idiopathic skeletal hyperostosis, degenerative scoliosis, hyperkyphosis, conditions that require a little different type of spinal manipulation. I'm going to quit at that point. I'll look forward to studying with you. Some of you will say, well, Jim, this is worthy of studying more. And if you do choose that, come to our certification course, which is sanctioned through National University of Health Sciences, and our 5 instructors, if you think that this is worthy of further study. Are there any questions?
Let me check. Someone asked about what type of CMT Wong used. I'm not sure. We'd have to probably look in the article to see, unless you know.
Can you get their name? I'll send them
Yeah.
the paper.
Yeah.
When you ask a
I'll get
question
that.
like that, you'll want to go to these papers and look at them. When you look at the Wong paper, did you notice one of the authors was Greg Kawchuk? That should give you an idea that Kawchuk is a proponent of spinal manipulation. So many of these are done with classic high velocity, low amplitude thrust, which is fine. I think that's what Wong was using, as a matter of fact.
I'll find out and send that for sure.
We'll send you the paper, and then you can study it. Every day, like I read 85 papers today. And when you read that many papers a day, I have to go back sometimes and look up real minutia, but I'm always happy to share that with you as well.
Okay, I got another question. With spinal scoliotic curves, regardless of the magnitude, do you only lateral flex into the convexity, or will you go into the concavity to aid
with motion improvement?
We laterally flex into the convexity of a curve. We also strengthen the paravertebral muscles in the low back, the quadratus lumborum by meta techniques. In fact, we will be having, what's the date, in April?
April 17, 18, thoracic spine.
We're going to have a conference in Fort Wayne, which will be extensively on treating both idiopathic and degenerative scoliosis of the spine. We will cover that in really heavy documented literature research. But yes, we laterally flex into the convexity of the curve. We strengthen the muscles on the convex side of a curve. That's what tends to reduce a curve. We won't laterally flex into a concavity or strengthen muscles on the concavity of a curve, because that would really only accentuate that curve.
I think that's it. And Dr. Poulin said, remind us of the certification course date, so I'll do that now. Online, if you want to study more on forces, you can do that online. If you look on the side here with the Cox seminars, I just had to cancel the San Francisco one. The hotel called, said no one's allowed to be meeting in person, so I just canceled that. We'll try and do a part 1 in the fall in San Francisco. We're doing a part 1 and 2 here in Indiana, Fort Wayne, April 29 and May 2. Our cervical course will be in Florida this weekend. If anybody wants to come to Florida, we still have room for you. It'll be a small group, plenty of social distancing. Dr. Cruz is doing. Our thoracic course, which will incorporate that scoliosis like Dr. Cox mentioned, will be April 17 and 18. I've got CE credits out there. National's doing them all. It should be a great weekend. I've had a lot of interest so far. So sign up. We'll be socially distanced. We'll do everything to make you as comfortable as possible and also be able to get together. Part 5 will be this fall, September. That will be on extremity sport and rehab issues that are all tied with Cox Technic. So keep those in mind. We have online, and we're also doing workshops. I just set one up with Dr. Hazen in Temecula, May 20th. So if you're out in California, we're going to do one out there. Visit Haven. They have this force table, has amazing tools that do measure your forces. You can have it in your office. It's of interest to you and your patients. And then see you for the next Wednesday webinar. Not sure what our topic will be. It'll probably be maybe the end of February. We've got several things going on in the next few weeks, but we'll find a good topic for the next time around. So let me check questions if there are any more. Someone said they missed part 1 of this webinar. Yes, there is a recording of the first part we did on January 6th, plus today's will be recorded, and I'll have that out, and I'll send a link to everybody. And also someone asked about the slides you opened with, the first 4 from your new research this morning. I will get those put together as well. Yeah, they'll be in the research pearls, plus I know you'll want them, just email me, but I will get an email out with those. So I cover that. He loves all things new. So no more questions. So time for you to go treat patients. Trust this works well. There's a survey at the end. I appreciate any feedback and look forward to seeing you the next time.